This is a sort of a challenge that after a lunch I have to talk on troubleshooting and management on ECMO. And it is the challenge is because it is an most important topic. And we have discussed already. Today is the day of troubleshooting, so we already discussed about the mechanical troubleshoots. And now I'll be discussing on the in general the troubleshoots which is patient related. And what I'm going to talk is, I'm purely going to talk on practical basis. And your staff comes and tells you, you are not getting enough flow, there's a flow issues. They'll come and tell you, saturation is dropping, or ABG is showing CCO2 is high, or patient develop hypotension, lactates are high, or urine color is dark, or there's a bleeding from somewhere, and some mechanical issues. Already the mechanical issues has been taken care, so I'll skip that part. Rest of the things I'll just cover up. And it will be more practical oriented. So I'll be talking on what will be an approach. So whenever you, as I told you, complications during ECMO is going to be a rule rather than a exception. Only thing is, how can you prevent it to become a dreaded complications. So ECMO is a blender of man and machine, so both the patient as well as machine can give you a problems. And machine related complications we have already discussed. So I always tell that whenever there is any problems, first thing you should always think about the machine related and technical issues, because that is easy to diagnose, at the same time it is easy to cure. Okay. And they are life threatening. See, when the patient is on ECMO, most of the supports are basically from ECMO. So even there are some patient related complications that even occurs because of patient, the lung worsening or parenchymal worsening, that won't be a life threatening. What is going to be life threatening is more because of the issues because of the ECMO per se, because the life is dependent upon ECMO. So that is an life threatening, so you have to diagnose it as early as possible. And it is, once you diagnose, it is easily correctable. So it's reversible. So that's the reason you have to always think of that as the first issue. So first you have to rule out technical issues. When I say technical issues means, first it starts with your calibration, whether whatever the readings you are getting is appropriate reading or no. So whether your pulse oximeter showing, your pulse ox probe is properly placed, suppose your pressures are showing low, whether it is been zeroed properly. So that will be the calibration errors. That is first thing you have to rule out. And then you have to look at the pressures, circuit pressures. Look at the ratio between flow rate, the blood and sweep gauge, whether whatever you set it is going the same. Check with the RPM and check with the connectors. Once you check all these and definitely the tube colors, you rule out anything grossly related to ECMO. Okay. So first of all, you have to always look into these parameters, and if you these parameters you don't wait for the investigation reports to come. These are in front of you. So you can just rule out these parameters. If these parameters are fine, means we are sure that nothing grossly related to ECMO is an issue. Now how do you approach to it? First thing is you have to recognize whether there is a problem or no. And at the same time, you have to think that whether that is an issue which is acceptable or you need to intervene. You don't want to intervene unnecessarily. If the saturation is 85, I will not like to jump into and get the saturation to 100, but definitely I like to evaluate the cause why it has gone to 85, but I won't jump for that. Okay. So how will you approach is, you first recognize and then judge whether to accept it or intervene immediately. If you need to think that you have to intervene immediately, what should be your immediate management? After finishing immediate management, it's not that okay, yes, everything is fine now, just you can just relax. You have to find out why at first place it has occurred. So you have to diagnose why it has occurred, and once you diagnose it has occurred, you have to find out a corrective solution for that so that it does not occur again. So this is the way you approach to the patients on ECMO. So I'll just first discuss the flow issue. So now tell me what has happened. What is happening? Flow is not constant and there is a chattering. Okay. So you diagnose it rightly, it's chattering. So what should be the immediate management? The moment you say chattering, what will be the immediate management? Decrease the pump speed. That is the immediate management. When you see chattering, the flow is going down. What you need to do is decrease the pump speed. Why? See, usual reflex is when you see the flow low, you increase the pump speed. If you increase the pump speed, it will create more negative pressure, cavitation, and then the chattering scenario will become air embolism because of cavitation. So whenever you see chattering like this, first thing you need to do is decrease the pump speed. Decrease the pump till the time the chattering stops. At one particular time, at one particular flow, the chattering stops. Once the chattering stops, gradually again increase the flow. At the same time, ask somebody to replace the volume. Okay. So decrease the pump and give bolus of the fluids. That is your immediate management for a chattering. But then you need to find out what is the cause, what has led to this chattering. Whether it is asynchronous breathing, whether it is hypovolemia, whether there is a problem in the cannula position, or whether there is a change in the patient position. So these are the 4 common reasons where you can get chattering, and you have to find out what is the cause and you have to treat it. If patient is if patient has asynchronous breathing, what you need to do is sedate the patient and paralyze. Whatever amount of fluid you give, you may not get the chattering stops or the flow improves till the time you don't sedate them and paralyze them. And once this has occurred, then you have to rethink why it has occurred and try to correct the cause. Might be your cannula may not be in proper position, you have to think about that also. If there is a hypovolemia, give boluses of the fluid, preferably colloids. Check albumin level. Transfuse Paxil if it is hemoglobin is less than 8 and transfuse albumin is less than 2.5. First 24 to 48 hours you get fluid leakage, that is because of surge reaction, that is accepted. But after that, if it is required, you have to think about what can be the cause. Check for the cannula position. See the change of patient position can help. If nothing helps, then you might have to think about putting an additional cannula for a drainage. But most of the time it is hypovolemia and you don't require to put the additional cannula. You should be okay with unless your cannula size is small, it should be okay with the replacement of the fluids. And that too, usually colloids. Okay. But as I told you, first 24 to 48 hours, this is expected. And if it occurs, fine. If it occurs beyond 24 to 48 hours, you have to look for either there is a bleeding or there is a new onset sepsis. These are the 2 things that always remain. or you have excessively diuresed the patient. So that can be the cause why it's after 48 hours, first 48 hours it can be just, you can just ignore as a ECMO related surge reaction, but after 48 hours if it occurs, you have to find out what is the cause. If it is a new onset sepsis which is occurring, then send the cultures, do PCT, escalate the antibiotics. If it is new bleeding, you have to control the bleeding and give blood transfusions. And if it is hypovolemia because of diuresis, you have to control that. The second problem that comes in the flow issue is, now what is the problem? With the same RPM, the flow is decreased. Okay, flow of 4.98, so RPM was 4198, flow was 5.9, and with the same RPM the flow is decreased to 4.67. So same RPM the flow is decreased. What will the immediate management? First, rule out the technical issues. If your sensor is not properly placed, if sensor is little loose, you might get you may not get the proper flow. So just check for it. Check vitals. If it has occurred suddenly, most probably it can be a kink in the circuit or somewhere. So look at it and correct it. Check the circuit pressures. Give bolus of fluids. And whether to treat it or no, or whether to accept, that is important. What has gone down is your flow has gone down. Okay. So with the flow going down, you can have a drop in saturation or you can have a drop in blood pressure also if it is VV ECMO or VA ECMO. So now whether this decrease in the flow, does it require to be treated? Then you might have to go up on the flow, increase the RPM, try to go up on the flow, see what happens, and then probably you have to correct the underlying cause. If the saturation or blood pressure is dropping drastically, if it is not dropping much, you can wait and watch and try to find out the cause and treat it. So again, diagnose whether it is a pre-pump pressure more negative, it is a hypovolemia that is the cause, and you have to give volumes. Okay. Again same, you have to give a bolus of fluids, preferably colloids, check albumin, check hemoglobin, okay. Check cannula position, do an X-ray, and change of patient position whether it can improve the things. Okay. Second is the delta pressure is increased. With the increase in delta pressure, you can get with the same RPM the flow can reduce. If that is the story, then probably you need to change the oxygenator. So look for the delta pressure high, change the oxygenator. Both pre and post oxygenator pressure are high. That means there is an increase afterload. That can be because of kink in the cannula tube, cannula blockage, cannula abating the wall, or increase SVR. So find out what is the cause is and try to correct it. If it is, you have to accept the raised SVR, you can just accept it, or you can use some vasodilators. And if everything is fine, pressures normal or decrease and that means, as I told you, is an obstruction in the pump. And what you need to do is look for the signs of hemolysis and you have to change for the pump. Now if it is a pump or oxygenator or cannula blockage, you have to increase your target for ACT. So it's not that you have just corrected it, but then when there is a clot, it means that whatever ACT you are maintaining, that is not enough to prevent the clot, and you have to maintain ACT on higher. So suppose your target was initially 160 to 180 and that is not helping, then you have to increase your targets to 180 to 200. So this is the way you go ahead. Technical issues, this is patient related. Technicals can be calibration, pressure line. If there is a blood in the pressure line, again it won't give you the proper reading of the pressures. Okay. And you have to find out whether it is a sudden, not constant, and gradual. If it is sudden, usually it is a kink in the circuit or cannula getting malposition or cannula is abating the wall. Usually it comes as a sudden drop in it. If it is not constant, fluctuating the way you have shown, okay, the chattering is there, the flow is fluctuating, not constant. It is usually either patient is agitated and you have to sedate the patient. If it is slowly the flow is decreasing, that means it is either a hypovolemia, cardiac tamponade can be the cause, or a cannula size is small. Tamponade can be because of the pneumothorax or pericardial effusion. You have to treat it, diagnose and treat it. And if nothing is going to help you, you have to think in terms of putting additional drainage cannula, especially if the cannula size is small. Now, how do you approach to hypoxia and hypercapnia? How will you assess hypoxia? Is the numbers tells you hypoxia? The answer is no. Numbers are not hard and fast that tells you hypoxia. Okay. So we decide to maintain PO2 of more than 50, but even accept PO2 of more than 45 also at times. Okay. What are other criteria to accept hypoxia or no? You have to assess the neurological status. If the patient is conscious, you are not worried. Monitoring the vitals. There is no tachycardia, no hypotension or hypertension. Lactates are fine. Urine output is good. Overall clinical scenario is fine. You are not worried. You accept whatever the saturation is. Okay. So don't only go by hypoxia numbers. It is the overall assessment of hypoxia that is important. Now, this all of you know, when the patient on VV ECMO, what are the factors determine the saturation? The ECMO circulation as well as the native circulation and the ratio of ECMO flow and the native circulation. These three factors determines the saturation in that. If your ECMO flow decreases, ECMO FR2 decreases, ECMO oxygenator fails, or there is a recirculation, all that can lead to hypoxia. If your ventilator setting somebody changes, again can lead to hypoxia if the lung is contributing. In the lung status worsens, patient develops pneumothorax or parenchymal worsening, again it can lead to hypoxia. And the most important last is your ratio of ECMO flow and native cardiac output. If your ECMO, any condition which increases the metabolic activity and which increases the cardiac output can lead to decrease in saturation, because in VV ECMO it is a dilution which maintains the dilutional saturation. So suppose your cardiac output is 6 liters now and your net ECMO output is 4 liters. You are almost oxygenating 75% of the blood. But suppose the cardiac output increases to 10 liters when the patient becomes awake or patient goes in sepsis or patient develops fever. You are just saturating only 40% of the blood. So there will be more dilutional effect and that can lead to hypoxia, and what you need to do is you need to get the cardiac output down. Okay. So the patient is on VV ECMO, saturation is 71. So what is the problem? Hypoxia. Now again, you have to decide whether to accept this hypoxia or you want to intervene. And how will you decide? Looking at the lactate levels, looking at the urine output, looking at the vitals, and looking at the neurological status. If all that is stable, you accept it. What will you look? First look at the tube color. Both the tube colors are fine. There is a clear difference between the tube colors. You are not worried. So the immediate management, first check the probe which is connected properly or no. Second, tube color. If the tube colors are good, you are not worried. Nothing grossly related to ECMO at least. Check the ECMO flow and FiO2. Check vitals. Increase ECMO flow. Increase ventilator settings if the issue is with ECMO. If you feel that ECMO is not working well, you might have to go up on the ventilator settings, but otherwise not required. You can increase the ECMO flow if you feel that you require to intervene. And if the patient is restless or asynchrony, just sedate the patient. Then you need to diagnose. If both the tube colors are dark, it is a sweep gas failure or blender failure that always occurs suddenly. and you have to correct that. Both are bright, all of you have seen now, it's a recirculation. It can be a flow issue, you are not getting enough flow, and because of that ECMO flow is decreased, and because the ECMO flow is decreased, the saturation is decreased. Okay. Increased metabolic activity, patient is awake, so again you can have an increase in the decrease in the saturation, and you need to treat it. So correct the cause, sedate the patients, and the fever, correct the fever, think about the antibiotics, and if there is a tachycardia and hypertension, give lobetalol. If not respond, there is no response to sedation. You can have air passage obstruction or mucus plug or clot, and if the lung is contributing, that can lead to hypoxia because the lung contribution goes down. In that case, you might to do therapeutic bronchoscopy. If there is pneumothorax, you might need to put ICD if it's a significant pneumothorax. Okay. So all that you can get diagnosed with the help of X-ray chest and ultrasound of the chest. If the hypoxia is gradual, it can be related to increase in the delta pressure or oxygenator failure, or can be because of the parenchymal worsening. What is important is to target hemoglobin high if your hypoxia persists. If your saturation is around 70, I'll prefer to keep the hemoglobin about 10 or 11 and try to maintain hematocrit high so that I can maintain the oxygen delivery. Okay. And if nothing helps, the last resource is going to be, as I told you, hypothermia or switch over to VAV ECMO. But that is as a last resource. So management, correction of causative factors, increase supply, or you can decrease the demand so that you can maintain the saturation. So correction of causative factors, technical issues, oxygenator failure, recirculation, improving the parenchymal, and correcting the demand and supply ratio. Now how will you improve the parenchyma? By bronchoscopy if there is a mucus plug or blockage. If there is a pneumothorax, put an ICD. Once the initial phase of ECMO gets stabilized, you can even diurize the patient and get the patient dry. There might be some amount of pulmonary edema which is playing a role. If lung starts getting aerated, you can try to recruit the lungs and the prone position. So if you see the bronchus blocked, you can do bronchoscopy and remove the clots like this. Give a prone position to the patient. Okay. As I told you, give the rest to the lungs, but not make it lazy. Give a physiotherapy, postural drainage, make them sit, mobilize the patient. So all that is equal importance. Usually what happens when we put the patient on ECMO, we just look at the saturation, we keep the patient absolutely immobile so that nothing goes wrong. And in that we are not helping the patient, but we are rather harming the patient because we are not putting any active efforts for the lungs to improve. If there is an increased metabolism, you have to use esmolol. There is a tachycardia, use esmolol. And there are papers which suggest that when the heart rate of 120, you are supporting only 50% of cardiac output. When the heart rate comes down to 80, you are supporting almost 75% of the cardiac output, and thereby you can increase the saturation. So sometimes you don't need to do anything with the ECMO. Just give sedation, just give lobetalol, and things will improve. And same thing with the hypothermia. If you decrease the temperature, the consumption will decrease, and thereby indirectly it improves the saturation. And that is what has been studied. With 37 degree temperature, the saturation was 82. Without any correcting factors, when temperatures come down from 37 to 34, saturation is 94. And that's the reason, if you see suddenly saturation improving 94 without any obvious reason you expect the lungs is recovered, always think that there is an hypothermia associated. Okay. Why don't we cool all the patients to improve the saturation? The reason is There is a risk of infection, the risk of arrhythmias, the coagulopathies, and drug metabolism gets altered. So this is the way you look at when you get a hypoxia. First, look at the tube color. If it is same, dark color, gas flow failure, bright color, recirculation. Look for the technical issues, whether pulse oximeter is connected properly or no. Look at the flow, whether the flow is decreased. If it is decreased, look at what are the reasons for it has decreased. Whether the patient demand is increased, whether the patient has got fever, patient is awake, restless, patient is going in sepsis. All that can lead to hypoxia. Look at the delta pressures, get an X-ray and 2D echo or sonography of the chest done to rule out parenchymal worsening. And how we'll manage the cause, I already discussed that. Next is hypercapnia. See, hypercapnia, you can get it at the time of weaning also, or when patient is on ECMO. At the time of weaning, if you get hypercapnia, you usually tend to accept because you go for a permissive hypercapnia. So that is important when you weaning the patient from VV ECMO, you consider it as a permissive hypercapnia, so you accept it and you don't intervene. But if it is during the ECMO run, you might have to intervene. Again, look at the tube color, that is most important. Immediate measurement, rule out technical issues, whether sweep gas is connected properly or no. Increase sweep gas if your PCO2 is high during the ECMO run. If it is not high, if it is weaning type, you might just ignore it. And if there is an issue with the ventilator, definitely you have to increase ventilator settings. So if it is only hypercapnia, rule out blender malfunction. If the patient is on central oxygen with the flow meter, there might be some leak in the flow meter, or the third possibility is membrane edema. Okay. So you have to increase the sweep gas. Your staff must not have done it overnight. So the CO2 is high in the morning. You have to increase the sweep gas to 15 liters, wait for 15-20 seconds, and again get back to normal. Okay, that is what you do. If it is associated with hypoxia, then again the same cause of hypoxia. The tube color, dark, sweep gas failure, recirculation can be the cause. Increased metabolic activity, increased delta pressure, and parenchymal worsening. So that remains the same as hypoxia cause. Okay. And you have to correct the underlying cause. Okay. So keep in mind about the membrane edema. That is most important. Okay. Usually, hypercapnia alone is more of a mechanical issues. There is no hypoxia, only hypercapnia, so it is more of a mechanical issues. Either there is a blender malfunction, or there is a flow meter problem, or it is going to be a membrane edema. You don't get only isolated hypercapnia otherwise. Now your patient is on VA ECMO, and if you have hypoxia, both the approach are different with VVA as well as VA ECMO. If it is VA ECMO and hypoxia, you have to find out whether it is a regional hypoxia or it is a whole body hypoxia. That is again most important. So first isolate if it is a hypoxia from where we are measuring the saturation. If it is from the right hand, if you have femoral cannulation, right hand hypoxia is usually a regional hypoxia, and probably because of the ECMO, VA ECMO per se. But if it is everywhere, the cause is going to be different. Regional hypoxia usually see because of differential north-south syndrome, or differential hypoxia, that is because of north-south syndrome. If it is generalized, look at the color of the tube. Okay, because that can be again a problem. So first rule out the technical issues, look at the color of the tube, both the colors are fine, you are happy. Look at the flow and FR2 and increase ventilator setting if there is a differential hypoxia, because your ECMO flow is not going to manage that part of the body because the flow is not going there. So they are dependent upon the ventilator. So you have to increase the ventilator settings. So again, same, both the colors are dark or bright, you have to look into that and correct it. So if there is a parenchymal worsening, X-ray chest and ultrasound that will tell you here is a differential hypoxia, so the heart improves but the lung worsens, so you get it. Again, you have to treat the lung for the condition. And in that case, again as I told you, we have to increase the ventilator settings, and if that is not helping, switch over to VAV ECMO. Now next is hypotension or hypoperfusion while the patient on ECMO. So you recognize hypotension when the patient on VV ECMO. First again, rule out the technical cause. Check the flow and pre-pump pressures. That will tell you whether the patient is getting more dehydrated or hypovolemic. If that is, give bolus of the fluids and start with noradrenaline if hypotension is severe. So, hypovolemia, give fluid boluses. Okay, you can give a bolus of the fluids, and then you have to find out why the hypovolemia has occurred. Whether there is some bleeding or whether the patient is going into sepsis, so you have to look for that cause and try to find out that cause and treat it. So if there is a bleeding, especially GI bleed can be an occult blood, which we may not be able to see immediately, and you suddenly get hypovolemia. So look for GI bleed, check hemoglobin, transfuse PEG cells, decrease heparin, target ACT, look for the coagulation factors, and if required, correct it. If it is sepsis, vasopressors, send fresh cultures and escalate antibiotics. Okay, because on VV ECMO, if there is hypotension, these are the usual causes. Can be a tamponade effect, look at the X-ray and chest ultrasounds. They can have acidosis, either metabolic or respiratory acidosis, and then you have to correct that. Patient can be going to myocarditis and going to septic myocarditis, so you have to give inotropes. If inotropic requirement is high, switch over to VAV. And another possibility, if the patient is on prolonged ECMO, say more than 20 days, 25 days of ECMO, you cannot rule out right heart failure. Right heart failure can be the cause because of low output state. And what you need to do is give dobutamine, noradrenaline, not responding nitric oxide. If not responding, then VAV ECMO. The next is hypotension or hypoperfusion in VA ECMO. Again, you have to decide whether to accept or intervene. If lactates are fine, urine output is good, neurologically patient is intact, you need not have to intervene. Okay. Accept the pressures if the lactates are fine. That means there is only hypotension and no hypoperfusion. So when we talk about hypotension in VA ECMO, you always have to consider in reference with the hypoperfusion, whether there is a hypoperfusion is there or no. So immediate management, technical issue to be ruled out, increase ECMO flow, fluid if the flow is not adequate. Now what are the causes? Why should you get hypotension when the patient is on VA ECMO? So it can be inadequate cardiac output, native plus ECMO. Both the cardiac outputs together is inadequate. Or even there is no hypotension and lactates are rising, that is an inadequate cardiac output. It can be a cardiac stunning, so low pulse pressure, hypovolemia or poor LV. Peripheral vasodilatation with good pulse pressure, your adequate flow, we have adequate flow, good blood pressure, and still hypotension that suggests more of a peripheral vasodilatation, and you get a low diastolic pressure, and you have to treat it with vasoplegia. It means that the vasoplegia can be a surge reaction or can be a sepsis. Persistent metabolic acidosis, we are not able to correct still lactic acidosis or a tamponade effect. These are all causes for a hypotension and hypoperfusion during VA ECMO. So your flow is not adequate, increase the ECMO flow, target lactates and not the pressures. Okay, that is most important. At the same time, target pulse pressure and try to maintain more than 10. If there's a cardiac stunning, Dr. Goel has already discussed about it. The first thing is you give, it might be LV empty RV which is there and which is causing the LV also getting empty. So give fluid sensitive, whether the cardiac contractility improves or pulse pressure improves. If it is a poor LV, then you think in terms of inodilators, either dobutamine, milrinone, adrenaline. Try to maintain the pulse pressure more than 10. If that does not help, you have to think of adding intra-aortic balloon pump for a cardiac stunning. And if that not, then you might have to think in terms of venting the LA or LV in future if the LV start getting dilated. If there is a peripheral vasodilatation, okay, or vasoplegia, surge or sepsis, again you have to manage with the fluid. Start with the vasopressors like noradrenaline or vasopressin. Okay, look for the new onset of sepsis. Sometimes we get severe vasoplegia, and some people has tried vitamin C, methylene blue, hydroxycolamine in a refractory vasoplegia. How much it is of use, nobody knows it, but then people has tried it, and some papers they are supporting it. If you have persistent metabolic acidosis, in spite of being this, patient is renal failure, bicarb, and start with the renal replacement therapy, either in terms of CRRT or in terms of SLADE. Again, tamponade effect you can diagnose with the help of X-ray and echo, and you have to correct it. Okay. What is most important is you have to maintain the pulse pressure more than 10, target lactates and perfusion and not the blood pressure only. These are the two factors which is most important. This is the most important point. First, you think about saving the life. Okay, why I am saying this? Because when you go up on the flow and try to correct the lactates, you might develop a cardiac stunning. So you are going to save a life, but the cardiac stunning is going to occur. So that is going to be a dilemma whether to go up on the flow or no. Because we always say that you can always blame us that we said don't go on full flow. But that is to prevent cardiac stunning. But if you are not going on full flow and the lactates are still rising, because that means that you are not adequately supporting the body. So first intention is that lactate has to come down. You have to support the patient adequately. Okay, that is the first thing. So first save the life, then comes saving the heart, and then comes the saving the end organ. So that is most important. So it should not be that because the pulse pressure is getting less than 10, so I don't go up on the flow. Yes, if your lactates are fine, you need not have to go up on the flow. But if you are still on that flow, lactates are rising, irrespective of whether the patient is going to cardiac stunning, because there is a treatment for cardiac stunning. But if the lactate does not come down, your perfusion does not improve, patient will not survive. So first give importance to saving the life, then the heart, and then the end organs. So you recognize hypoperfusion. Okay, this I already discussed how you recognize it. Why I am insisting on lactates? Because there are various papers on VA ECMO and lactates. And cause of lactate elevations are multifactorial, so you have to find out what is exactly a cause, whether it's an anaerobic metabolism, hepatic failure, catecholamine, poor tissue perfusion, or renal failure. What is more important is lactate dynamics. And there are papers which says that the survival of more than 30 days in the patient where the lactate level has come down, okay, within 24 to 48 hours statistically, they have a better chance of survival as compared to the patient where the lactate level has come down slowly or it has not come down. So that's the reason it is important that you have to support the patient adequately, and lactate should remain your targets. So lactate remains a predictor of mortality in adult cardiac ECMO. That is most important, you should remember. So there's a vasoplasty, as I told you, managed with noradrenaline, vasopressin, phenylephrine, or refractory shock, methylene blue, hydroxycobalamin, angiotensin 2, ascorbic acid. These all are on the trial basis. Nothing has been significant papers which says it can be taken as a guidelines. Okay. So I'll just keep these slides. Okay. The dosage and everything I've written. I'll just keep that slides. Next is your hemolysis. And all of you must have seen these pictures which suggest there is a hemolysis. Your staff comes and tells you dark color urine. It can be hemolysis, can be hematuria or bleeding. Check the urine color in the tube. Don't look at the color here. Check at the color in the tube, because this color will take longer time to change. The tube color immediately tells you what is the current picture. Check the circuit pressures. If the P1 is too negative, that can lead to hemolysis. If your P2, P3 are too high, again that can lead to hemolysis. So find out what is the cause. If your delta pressure is high, again it can lead to hemolysis. So you check the circuit pressure, you will get the cause. Okay. You bolus of the fluids, and the hemolysis is significant, and you have to think in terms of, to preventing the kidney, think in terms of alkaline diuresis. Send urine for hemoglobinuria or a plasma-free hemoglobin to confirm the diagnosis. If the pre-pump pressure is too negative, as I told you, then you have to give fluid boluses. Okay. Preferably colloids, albumin, hemoglobin, low blood. If cannula size is too small, add even more cannula. If you put a small size cannula, that is the commonest cause which can cause a hemolysis. And then in that case, you need to put a additional cannula. If there is a clot in the circuit, change the circuits. Clot in the oxygenator, change the oxygenator. Both the pre and post oxygenator pressure is high. Again, you have to look at the causes for increase after load and you have to correct that. All pressures are normal. That means pump is an issue. Pump is more than 8 days old, especially Medtronic. Again, that can lead to hemolysis because of the pump gets warmed up. And when the patient is ECMO, it doesn't mean only you think in terms of ECMO. There are other than ECMO which can cause hemolysis, that also you have to keep in mind. And the commonest which is related to ECMO is your blood transfusions. So you need not have to rule out the possibility of mismatched blood transfusion. And if it is occurs, you have to inform the blood bank and alkaline diuresis. The next thing that patient staff comes to you is they say there is a bleeding on the patient on ECMO. So if there is a bleeding, if it is a compressible, compress bleeding and control it. If it is a massive bleed, give fluid boluses. If there is a bleeding with hypotension, give a fluid bolus, and blood transfusion if there is a massive bleed. You need to find out why it is, whether it is a localized bleed or it is a generalized bleed. Localized can be cannula site, GI bleed, pulmonary hemorrhage, IC bleed, surgical bleed at the surgical site. Or generalized can be because of excess heparination or some coagulopathy. So need to find out the cause. If it is just a cannula site, just compress it. Sorry. Okay. If it is a local, just give some local medication. If it's a GI bleed, give pentoside infusion, octreotide or somatostatin if you need to give. Do a local intervention. If it is cannula site, just take a suture and see whether bleeding stops. If it is pulmonary hemorrhage, do bronchoscopy. If GI bleed, do ogidoscopy. If required, sclerotherapy or embolization. So whatever needs to be done for local, do local for a local bleed. Okay. At the same time, you have to treat the complications related to local bleed. For an example, if there is a IC bleed, there will be increased cerebral tension, so you have to use decongestant, cerebral decongestant, you have to use anticonvulsant drugs, okay, anti-edema measures, and if required, craniotomy. If it is generalized, excessive heparination, stop heparin for some time or decrease heparin. Okay. Look for an advanced coagulation monitoring like TEG, ROTEM or sonoclot or anti-NA factors. Correct the clotting factors if you can identify and correct the clotting factors. And then need to work upon why the coagulopathy has occurred, identify the cause of coagulopathy. As I told you, coagulopathy can be sepsis related or it can be circuit related also. So you have to always look into that, whether it is because of sepsis or because of circuit or because of some drugs, so you have to correct and treat it. Okay. It can be because of hypothermia also, so you have to correct the hypothermia. I think this I had discussed already, extended decanations, I'll just skip that. Thanks.